I was asked to talk about the 10 commandments of total knee arthroplasty, and I want to actually walk you through certainly my philosophy of knee replacements. Um, I would start by saying that this is a session where I would encourage you to ask as many questions as you want, both from the panel, from the moderators, and it'll be a real pleasure to interact and try and answer the various questions. So the format is I have a few slides, and at the end of the slide there is a video demonstration of about 9 minutes that captures all the essential points of the presentation and the talk. And at the end of it, we're very, very happy and would encourage all of you to discuss, and we will try and address all of those questions. So the real issue with total knee replacement is we started off by saying, what are the patients, who are the patients who need this surgery? So for a long time, as Dr. Saraf started to ask me, why have things changed, or have things changed? Are we in sync with what's happening in the other specialties? So let's walk our way through some of these questions, and we can debate them at length later. So there are basically 5 issues that you need to understand when you contemplate doing a knee replacement. The first is the indication. The second is the patient selection. The third is the implant selection. Then, of course, you have the surgical technique. And then possibly what I believe is the most important part of knee replacement, which is your rehabilitation process and the issues. So let's start walking our way through some of these. Indication issues may actually sound very obvious, but you'll be surprised at how many times a patient is operated for a knee replacement because he complains of pain in the knee because of referred pain, which may be from the spine or the hip. There are issues in the abdomen, the pelvis. So the first point is, when you see a patient, make sure that his pathology or pain in the knee comes from a disability or pathology in the knee. So what I'm really sort of mentioning here is a thorough clinical examination is mandatory before recommending a total knee replacement. Very often, we've seen this way too often. A patient undergoes a total knee replacement, is not satisfied, continues to complain of pain, and eventually you find that this patient has osteoarthritis of the hip with the referred pain into the knee, and not surprisingly, he is a dissatisfied patient. Now, the second point is patient selection. And the most important thing is to understand before you start that you need to identify those patients who you know whatever you do are not going to do well. These are patients who have psychological issues, who are stubborn, who will not listen to reasoning. There are a lot of patients who do not have a lot of family support. The typical example are families whose children are overseas. They come here for 2 weeks, get the surgery done, and they leave, and then the patient is left unsupported. They may not be able to understand instructions, and they don't know how to reach out to the treating surgeon. And the most important individual in this category are patients who have unrealistic expectations. And we'll talk through this. For instance, a patient who's been bedridden for about 5 years, has never walked except on a walker or wheelchair, expecting to be able to sit cross-legged on the ground and walking 2 kilometers 2 months after surgeries. These are the patients who are not going to do well. You should be able to identify those. The third issue really is the implant selection and your preoperative planning. I think this is the key to success. I have over the years stuck with one, maximum 2 companies. And I'm not trying to recommend one or the other, but what I would very strongly advise is get comfortable with one implant system, maybe 2. And when you are operating on these patients, make sure that you have all the size options, all the different inventory for the types of constraints, the various polyethylene types, and most importantly, in difficult surgeries, make sure that you have an option that in case your plan A does not work, you have a fallback plan B, and for the plan B, you have the appropriate number of implants or sizes or different types of knee systems available to you. So the preoperative planning is very necessary. I think it's important that you see these patients clinically, you get the radiology, you get weight-bearing x-rays, you x-ray the pelvis, you x-ray the lumbosacral spine, check the peripheral vascular issues. Long leg legs are x-rays are particularly important because if there's an extra-articular deformity, you might miss them if you just get the knee x-rays, which is why we always emphasize that long leg x-rays, what we call the alignment x-rays, are very, very important before embarking on a total knee replacement. These are the short x-rays, which will do in most cases, but even as a scanogram, just look at what the overall limb alignment is, because very often you might have a pathology in the hip or in the shaft of the femur or the tibia, and if you don't factor that in, you'll probably end up with a malaligned limb. These are templates that are available with most implant systems. I put this really for the sake of completeness. Honestly speaking, today, we almost never used templating, but for those of you who are starting off, I would very, very strongly support the idea of getting your company man to bring in the templates, template these x-rays, make sure you factor in that these are 15% enlarged, and accordingly, you can choose your sizes. So if you have a challenge of having maybe 2 or 3 sizes, you'll be pretty close, one size up, one size down. You don't get stuck out for want of the right size. Now, there are really 10 key points, and these are what I call the 10 commandments. You can vary this any which way that you want, but these are the essential 10 things that you have to do before you get a good knee under your belt. The first thing is a proper exposure. I mean, we've all been through, those of you who have been in the business long enough, in 2002, 3, 4, 5, we had this magic word called the MIS, knee replacement surgery, which was the biggest disaster. Both on the hip side and the knee side, people were competing with each other. 4-centimeter incision, 5-centimeter incision, 6-centimeter incision for hips and knees. And that was an absolute disaster. There is no place for MIS in knee replacement or hip replacement. You do not need to make a 14-inch incision, 4 to 5 inch, but make an incision long enough for you to be able to see. You have to have a standard in your mind. On the femoral side, our typical go-to is for a varus knee, we use 5 degrees of valgus. For a valgus knee, we go to 3 degrees of valgus. We believe in the philosophy of the mechanical alignment. There are now 5 other different ways to align the implant. We have stuck to the tried and tested with that I started almost 35 years ago. And we cut the tibia at right angle to the shaft, and we cut it in about 5 to 7 degrees of posterior slope. I'm primarily a CR cruciate retaining surgeon, so that works well for me. If you're a PS surgeon, you do it at about 3 or 4 degrees. You ensure correct femoral and tibial rotation, and I cannot overemphasize that this is the key to getting a good knee. You need to balance your flexion and extension gap. Make sure that you're not oversizing the knee, because that is stuffing the joint, and you'll have stiffness, you'll have pain, you'll have movements which will be compromised, and overall a very dissatisfied patient. We started off in 1987, 88. For almost 10 years, I did cementless knees. They did very well. For various reasons, cementless was not available, and since 87, we have been, since 97, we have been cementing all our knees. And there is a technique to it, and we'll just very briefly talk about this as we go along. What sort of cement do you use? Do you use antibiotic cement? We typically use antibiotic cement only in patients who are at risk, patients who are diabetics, who are rheumatoid, immune compromised, renal or liver transplant, post-malignancies, patients who have had immunosuppressants. We then come to the ninth issue, which is start your physical therapy early. Talk to your patients before surgery that they will need to rehab and start their rehabilitation early. And last but not least, if you do happen to be unfortunate to have a complication, recognize it early, treat it aggressively. So the long-term success depends on these four issues. You have to have your limb aligned, your joint aligned. You need to make the right bone cuts. You need to have the right soft tissue balance, and you need to have correct rotation. And these are all 25% of the 100% that you need to get a good alignment. I worked with John Insall, and at the time in 99, 2000, when I was with him, he always used to talk about knee replacement surgery being a soft tissue surgery. Today, we know that is only partially true. There's a lot more to knee replacement than just balancing soft tissues. And some of these are outlined in these 4 pointers. Now, typically, if you do a knee that is not done correctly, you see these x-rays. These are all mal-rotated x-rays. And this is very easily done, particularly in obese patients who are stiff, where your exposures are not good enough. And you will find that the x-rays on the left are all preoperative, they're malaligned. And the way you diagnose that is if you see the x-ray on the left, the femur looks a perfect AP, while the tibia looks, the lateral side flange is much longer. So that tells you that your tibia is internally rotated. The same thing on the x-rays to your right. The preoperative x-ray, you see that the medial flange of the tibia is longer than the lateral one. And both of these patients needed revision surgery. So what are we trying to do? We're trying to restore the mechanical axis. And what is the mechanical axis? And way back, 1984, John Insall talked about the mechanical axis being correct when the center of the hip, knee, and ankle are in the same straight line. There have been several variations now, and there are various other alignments like the constitutional, the anatomical, the kinematic alignment, the modified kinematic. So there are different schools of thought, but by and large, this has stood the test of time. And today, a lot of the arthroplasty conferences, there are lots of debates on whether the constitutional alignment is better or mechanical or kinematic alignment. The one thing we know is that you do not want to have your tibia or your femur cut in varus, because in varus, there's 67% chances of failure. Interestingly enough, in a neutral alignment, there's 20% chance of failure. It's the most valid way to go about is to have a 6% valgus, which is really what we're trying to do when we are cutting your femur in about 5 degrees of valgus in the distal femur. So these are the fundamental principles. And again, these are John Insall's slides that you very kindly, and these are slides that have become like the Bhagavad Gita of knee replacement presentations. You have a quadrilateral gap. You correct that because by releasing soft tissues medially or laterally, depending on what you want, and you align this so you get from a quadrilateral to a rectangular gap. It's also important to understand the fundamentals of the knee replacement, that the distal femur only influences the extension space, while the posterior femur only influences the flexion space. So once you've understood this part, you understand what your cuts are doing as far as the femur is concerned. We then move to the tibia, and the interesting part is that the proximal tibia influences both your flexion and extension space, which makes the tibial resection absolutely the critical cut and the critical alignment issue. Now, all of you have gone through this debate, and you have, I'm sure, in your own minds been worried about, should you retain the cruciate, should you sacrifice it, should you cement, uncement, fixed bearing, mobile bearing, do rheumatoids do well, do osteos do well, does age influence the outcomes? Let me just sum up this whole slide and answer it in one line. None of these factors make any difference. your cruciate retaining does as well as cruciate substituting. The young patient does as well as the old elderly patient. Rheumatoids do as well as osteos. Fixed mobiles done well will do almost as well. And if you look at the Australian or the Norwegian or the Finnish or the Swedish registry, there's a 1 point difference between all of these options. What really matters is how you do your surgery, how well you balance your soft tissues, and how well you fix your components. Now, what is the ideal alignment? Again, it is a debatable subject. So I'm going to talk in context with what I do, which is the mechanical alignment, and we use anatomical landmarks. Now, these are easy to find in a primary knee. Most often, they're also easy to find in a revision knee, but we're not going to talk about revisions today. We're just going to talk about primaries. So the anatomical landmarks, we'll just talk about it in a minute. More recent developments, you've had a lot of talk about navigation options. Navigation is out of the window. Very few people actually use navigation. You'll be surprised in the year 2000, of the 100% that were using, 3% have retained navigation options today. We went through the patient-specific instrumentation. This came and it went. And there was really no clear advantage of knee replacement done by under navigational control or conventional control. I'm aware that some of you are familiar with the new buzzword in knee replacements, which is robotics. I believe some of you may have had exposure to this. We have been using it now for almost about 4.5, 5 years. Are the results better? We think it might be at least as good. We do not know if it will be better. But the one thing that is the downside to this is that the costs are a huge issue. They're very expensive. They cost in the region of about 6 to 8 crores. And obviously, realizing that amount of money is going to be a challenge. So in terms of surgical technique, you have done your exposure. Whatever way you have the mid-vastus, you have the anteromedial approach, you have the subvastus approach. These are the clear approaches. In difficult knees, you can do the rectus snip. Again, these are more revision concepts we're not going to talk about. You then do your bony cuts, and then you do the final adjustment with the final ligament releases. Now, rotation, when you talk about the femur, these are the 4 issues that you need to consider. The AP axis, this is the right side line. You have the transepicondylar axis, which is easy to find, the posterior femoral condyles, and the transtibial axis. So the transtibial axis is used by people who do the tibial resection first. And these are usually going to be your PS surgeons. A lot of them will address the tibia first, they subluxate it anteriorly, do the tibial cut, and then orient the femoral rotation relative to the tibia. I don't do that. There's nothing wrong with doing it that way, except that you have to be absolutely certain that your tibial cut is absolutely at right angles to where you want it to be. But these are all the 4 landmarks. Typically, it helps if you use more than 1 landmark. So we use the transepicondylar axis and the AP or the right side axis. On the tibial side, you can use the medial third of the tibial tubercle, or you can use the extramedullary guide for the first web space. We've modified this, and I would like to say that we now use the tibialis anterior tendon. That is your most accurate index. And if you use that as your landmark inferiorly, you'll cut almost always at absolute right angles to the long axis or the mechanical axis of the tibia. And that's really what we use. The second step is to start to remove the osteophytes in a varus knee on the medial side, on the lateral, in a valgus knee on the lateral side. By doing this, you release the tension. In a flexion deformity, you recreate your recess. You create your medial recess, your lateral recess, and your posterior recess. And then you address the PCL. Those of you who are PS surgeons will sacrifice the PCL. Those of us who are CR will decompress and balance the PCL. So on a varus knee, and remember, whatever releases you do will always be sequential. Do a release, check the limb alignment, do a little more. That way you titrate your releases, you do not over-release. And this is what we do. This is the order we follow. The capsular ligament, which is the meniscofemoral and meniscotibial ligament. We rarely go as far as the semimembranosus, except in very severe 30 degrees varus knees. We almost never release the superficial MCL except in patients with very severe flexion contractures. I retain the PCL in 95% of my knees, and the pes anserinus you will only do when the knee is subluxated by over 35 to 40 degrees. But this is the sequence in order of what you may want to release. On the valgus side, these are the more difficult knees. They're usually rheumatoids present valgus. So you start with the lateral retinaculum, the iliotibial band, the fibula collateral ligament. Sometimes you may have to release that. It's extra articulate, causes no instability. You then release the posterior posterolateral capsule. I keep the PCL, but if you have to release it, I would subperiostally release the lateral gastrocnemius. And popliteus is the last structure that you should release, remembering that if you release the popliteus, you might end up with a posterolateral instability. And if you do, then you're going to need a constrained option like the TC3 or the LCCK. So be very careful. In severe deformities, like I said earlier, make sure that you have fallback or plan B options. In severe flexion contractures, release the posterior capsule, remove your posterior osteophytes. Again, recreate the recess. Recess is basically the potential synovial space that normal knees have that gets obliterated in severely deformed knees. You can resect the distal femur, but that raises your joint line, can cause flexion instability. And we have even very severe knees with flexion deformities released the PCL, but retained it, not actually sacrificed it. So this is really what we are trying to do, releasing the osteophytes and recreating the recess. These are the posterior osteophytes. You must remove these because this decompresses your posterior capsule, the flexion space, and you're then able to extend the knee a lot easier. So at the end of your surgery, what is acceptable? You should have 1 to 2 millimeter opening of the medial side in about 5 degrees of flexion, looser lateral side. And if you are a PCL surgeon like me, you may want to make sure that your femur articulates with the middle third of the tibia, as you can see over here. On the lateral side, that's the way you need to make sure that it is aligned. You need to make sure that the tibia is under the femur. And if you, as you flex, the tray starts to lift off, that means your PCL is tight, and you might want to either release the PCL or sacrifice the PCL and go to a PS type of an option. Oversizing the femur will overstuff the joint, or resecting the patella will also overstuff. If you're between sizes on the femoral side, go for the smaller size and make sure that your patella is the same thickness as it was before you resurfaced it. And finally, today, most implants that are available with all the companies that are marketing knee implants, their implants are very patella friendly. So even those of us who do not routinely resurface the patella, we have excellent patellar alignment and tracking. We come to the most critical part. I think this is the make or break. Make sure that you have your anesthetist do very, very good postoperative pain management, because if you do not do this, the patient is going to be apprehensive. So we use a lot of intra-articular infiltration. We use patient-controlled pumps. We use adductor canal blocks. We use cord box, which means the sciatic, obturator, quadriceps, the obturator nerve, sciatic nerve, and obturator nerve. And we use the posterior capsular infiltration. Always remember, if a patient is in pain, he's not going to walk. And today our aim, which we achieve, and I think about 90% of our patients, our knee TKR patients will get operated in the morning. By 3 o'clock, they will be standing up and walking. And our unicompartment patients stand up and walk within 4 hours of the surgery. And I think it's very important from a morale point of view. that patients are mobilized early. So finally, a successful outcome of a knee replacement is a marriage between a cooperative patient, well-done surgery, and an excellent pain protocol rehabilitation system. And finally, I cannot overemphasize this. Um, the patient's expectations must be realistic. I mean, patients who are promised 150 degrees of knee flexion will always be a problem child for you, because very few knees will go to that length. And a realistic expectation is about 120 degrees of flexion. Globally, that has been the recognized figure, plus minus 5 degrees. Either way, you get the odd patient who can do much better, but predict about 115 to 120, and you'll be in the right sort of a ballpark. Um, if you do have complications, we all do, make sure you do not sit on it. Don't think it's going to settle down. They don't. Most important, if your wound is not healing, remember, there is no such thing as superficial infection. A knee that is discharging, knee that is bleeding, wait for 48 hours, does not settle. Take the patient back into the operating room, open it up, clean it up, see if you've got a bleeder, see if there is something gone wrong. Is there a fracture? We all treat other people's complications better than we treat our own complications. Make sure you don't do that. And treat prophylactically for DVT. I mean, we are great believers in the mechanical system of prophylaxis. DVT prophylaxis, we use mechanical pumps, DVT stockings, very early mobilization. We use enoxaparin for the duration of hospitalization and aspirin as they go out, particularly now with the COVID. And most importantly, do not manipulate, and tell your physios not to forcibly encourage increase in movements, because these will end up with fractures, patellar fractures, loosening of the implants. So this is something that you need to talk to your physios about and make sure it does not happen. So we'd like to just go on to this surgical video. And at this point, may I just suggest, please feel free to ask questions as you're going along. So this is a very severe osteoarthritic patient. We use a vertical midline incision, and we use a cautery to do a fairly generous medial release. At this stage, what we do is we take out these intercondylar osteophytes. This will decompress your anterior, your PCL. You've already excised the ACL, so all knee replacements are ACL deficient. You really have the choice of retaining the PCL or not. This is the white side land that we were talking about, and this is the transepicondylar axis. This should cut at right angles. And this is really what we follow in all of our cases. This is the intramedullary jig going in. This is the persona system. I was actually both privileged and blessed that I was one of the developers for the persona system. So I know this system rather well. It's an elegant system. That's not to say that other systems aren't good. They're all very good, but we just work with this. I do the distal resection first, as you can see over here. And once we have done that, this is at 5 degrees of valgus. Once we've done that, we next use our sizing option. And between sizes, for a CR, you downsize, for a PS, you upsize. This is the femoral finishing guide. You need to be a little careful as you go to the back. You have the chamfers, the anterior resections, and make sure you try not to notch the anterior cortex. Very important, because that is one of the forerunners of a supracondylar fracture, particularly in elderly, obese, osteoporotic female patients. So once you've done this, we remove the intercondylar osteophyte and posterior osteophyte. You can see over here that the PCL is getting tented. So we are removing the a large intercondylar osteophyte. And right next to that is the posterior ossified, and you can see that we have removed both of these, and this very nicely decompresses the posterior cruciate ligament. So you balance the medial and lateral side, and you balance your PCL with your patellar tendon. And at that point, you'll usually find if there's any loose body sitting there, you can take a Coker's and basically just try and remove that. So once you've done that, you then do your meniscectomy, or if there's any residual meniscus left, you try and remove that. And this is a classic methodology that I learned from Dr. John Insall many, many years ago. By releasing your lateral meniscus, you can actually subluxate the knee forward. You'll notice we are not using any Hohmann retractors. This is one of our specialties. A lot of people wonder how we do it, but you can see even without a Hohmann retractor, we can sublux it very nicely. We then use the tibial resection guide, and it has 10 millimeters and 2 millimeters, so 10 millimeters from the intact surface, or 2 from the defect side. And fundamentally, what you want to do is to try and keep your posterior slope similar to what you had with the patient preoperatively. So you reproduce the native slope of the tibia. One of the tips I would like to suggest is resect very, very, very little tibia. I mean, they recommend 10 millimeters. Almost always our resection is about 6-7 millimeters at the most. And the more severely deformed the knee is, remove less and less tibia. That will give you a very stable knee, particularly as in our case, we are cruciate retainers. It works very, very nicely. And you can see here that even in this very severe deformity, we are managing to retain the cruciate, and we have taken it out from the back. You can see the intercondylar notch very nicely. You then size your tibia. Again, with the Persona system, you have a wonderful option on sizes, and I don't use spacer blocks. For those of you who are wondering how we're doing this, we use the trial implants as our spacers, and it takes 2 steps out of the surgery. It hastens it, and by doing it this way, we are very well within the comfort zone of knowing how good your trial is going to be and how good your implant is going to be. So once you have satisfied yourself, one of the other things with the Persona is you can go up or down by a millimeter without actually having to remove anything. We call this the SHIM, SHIM system. We can just take this little metal piece and just bang it in, and it goes from 10 to 11. Otherwise, you'd have had to remove the femur, then the tibia, and then redo the whole thing. This is a very elegant system. So this is one of the advantages of some of the modern systems that we have. So once you're satisfied that you have a good stability, check the stability in full extension, 30 degrees flexion, 60 degrees flexion, 90 and 120. Always don't do only extension and 90 degrees flexion. And that's what we're trying to do over here. So once you're sure that you've got your sizing right, you drill your lug holes for your femur, and you can see over here that your PCL is beautifully maintained, and you are now ready for the final cementation. Just a word about the cementation: make sure that your bed is completely dry. So we use suction irrigation. You size your tibia. This is an asymmetric tibia, and you align the rotation in line with the what we call the Agaki line. That is the line from the attachment of the PCL to the tubercle middle third. This we are using the heel guide, and so all our bony preparation is now done, At this stage, any final tuning, any little residual osteophyte that you have, this is the last step of preparation. We drill multiple holes for good cement penetration. This is a 1.8 or 2.7 drill bit, multiple holes, about 20, 25, 30. This is the periarticular infiltration that I was talking to you about. This has adrenaline. This has 2% sensocaine, clonidine. Of late, we've been injecting tranexamic acid into the subcapsular area to reduce bleeding. Our typical blood loss is in the region of about 150 to 175 cc. So on a bilateral, we lose about 250, maybe 300 cc. We try as far as possible not to transfuse our patients. We know for a fact there's enough evidence that transfusion is one of the leading causes of infection. So we repeatedly use lavage, and this is your femoral component, and you remove any extruded cement, and that's your post-operative X-ray of the patient who was severely subluxated, and that is the end of the surgery. So with that, I come to the end of my presentation. I want to thank all of you for the opportunity to present to this wonderful group of friends.